Everybody, welcome back to the Association of Cannabinoid Specialists. I'm your host, John Malanko, with the leader of our group, Dr. Jordan Tischler. Good to see you, Doctor. Dr. Suraj Tandon, good to see you as well. Dr. Jehan Marcu and Dr. Sandra Carrillo. So welcome. Sandra is new, I should say new to our group, but new to the casual conversation. So pleasure to, and thank you for being open to join us here today. So Sandra, we covered quite a few different topics over this past, I guess, casual conversation year. And the topic that we'll, for you as well as for our listeners, we'll be speaking about covering contraindications, indications to cannabis use. And so, as you've heard, cannabis is not a one-size-fits-all. I truly believe a medical professional should be involved. We're not 20 anymore, where we go down and try something, go, oop, won't be doing that again, type of thing. So, but especially when it comes to certain ailments, we're all, I guess, created equal but different, if you want to get politically correct. Age, weight, current health conditions, sensitivity, stages of ailments that you may or may not have. And then we'll even get into drug-to-drug interactions, another reason why medical professionals should be involved. But the I'm going to say this message a few times, contraindications of cannabis use has to do with different ailments. And so I know we started off the call, Dr. Tischler, if you want to share some of what that is. Cannabis is not for everyone, and it does not work. And some people are highly sensitive, depending on schizophrenia to liver disease, what Dr. Marcu was sharing with us at the off camera as well. So if you could start us off with this, that would be wonderful.
Sure. I think that it's interesting that I was saying earlier that I've spent a lot of time over my career trying to think about what are the absolute contraindications, never mix cannabis with, and there are a few that are kind of eyebrow raising, like significant relative contraindications, but it's pretty hard to find, absolute issues. There are certainly some medications that some cannabinoids interact with that are particularly dangerous. Less so, again, with the THC and more so on the CBD side, things like amiodarone, tacrolimus, warfarin, those sorts of things. But even then, again, if you know what you're doing, meaning if you know the patient is on all of those things, you can be cautious about it. But when I really think about sort of disease states that you talked about, they kind of fall into three categories as far as I can think of: cardiologic, neurovascular, stroke risk, and then mental health. You mentioned the schizophrenics and the bipolars. And again, none of those things are hard and fast, no, you must never do this, but it's more like you have to figure out how significant these issues are for this individual patient. And sometimes that involves, for me anyway, going back to their other doctors and saying, well, what do you guys think? If nothing else, it's good to have everyone weighing in so that it's a group decision and not just sort of my recommendation. But those are sort of the ways I tend to think about things.
Good, and I think across the board too. And so Sandra, with your patients down, and you're doing Colombia and Panama, correct? Is where you're going back and forth. And congratulations on Colombia just recently legalizing medical cannabis. And is that across the board for recreational, or is it medical? How?
It's Panama, the one that we just recently legalized. So we are just working with the regulation. That is the hard part. Passing the law is a lot of effort, but the regulation, it's a lot of work for the government, since the government really don't have a lot of knowledge about this, and it's not their fault because this is like something new for them. Yeah. So my clinical practice is actually in Colombia. And regarding to contraindications, I also think more about drug interactions that I am very aware when I take a patient for first time. And I do a lot of teaching at universities and for doctors. And I see this is the main concern of all of them. And they're always worried because they don't know. And they call me and they say, because usually the patients we see are patients that are coming with polypharmacy, that they're taking 3, 4, 5 medications. So the doctors, and I see this is the main thing that is restraining doctors to prescribe medical cannabis, most of them specialists or even GPs, because they don't know these interactions and they are afraid. And I actually read in a study, there is not a medication that cannot be administered with cannabis, but as following what Dr. Tischler say, we need to be cautious. I mean, there is interactions, let's say with clobazam, with valproic acid, and it doesn't mean that they cannot be administered concomitant with the CBD in this case. But it's in here that is so important, the education for the doctors and have the expertise that they need to reduce the doses of clobazam in order to avoid the side effects. So drug interactions a lot, and with CBD, I see more than with the THC even. And I always try to tell doctors to be aware of this, because I am in favor of destigmatizing the use of cannabis, but I disagree with trivializing it, because they are trivializing the use, and they are thinking that because it's CBD coming from hemp, is nothing happened. And I've seen patients saying, oh, I am taking benzodiazepines and I'm taking CBD 50 milligrams, 100 milligrams because it helps me better. And I think it's there where you need to be aware that there is interactions, and the patients and the doctors need to know. And even doctors, they don't know, and they say, oh, I didn't know that CBD could interact with benzodiazepines. So this is where, when we start seeing that maybe something happened to the patient, wasn't the CBD, was the benzodiazepine. So yes, and contraindications, as Jordan said, they're relative. I always, I'm very careful with patients with unstable cardiac conditions, particularly those ones that they have atrial fibrillation or tachycardia. And I always work with the cardiologists on that matter. And of course, avoid the THC. That is mainly the one that they could cause these problems here. And also I see, and I'm cautious also with patients that have a background of abusing other substances. So being careful with that. But I see medical cannabis that regarding to side effects and drug interactions, that is very important that the doctor has a very deep training on this, because I think this is the part where, as doctors, we can really make mistakes and cause some side effects that are not going to be necessarily lethal, but they are going to be unpleasant for the
uncomfortable.
So
yeah,
it's important to keep that in mind.
You made mention about education with government, and you also included doctors in there. It's not only down there; it's here in America as well, where cannabis laws are being changed for the better in most cases, but they're not educating doctors. So all these states are becoming legalized, but there's a shortage of doctors that truly know about. It's not a one-size-fits-all dosing, contraindications, drug-to-drug interactions, et cetera. And so I applaud you for what you're doing down there, leading the way and being the pioneer. And as Jehan said, go get it, kid. so well, we were south of the border. Let's go north of the border, up in Canada. Siraj, what are your thoughts on this? I know you work with a lot of patients 18 and over. And so this must come up quite a bit. And are there times that you steer patients away from cannabis, saying, I really don't feel comfortable that this is a modality you should try, and there are other options out there?
Yeah, absolutely. So I think just touching on some of the the other, contraindications of use in specific age groups, specific populations. What I'll add to it, and just obviously I'm here in Canada, so the laws and regulations are a little bit different, but more or less, they're fundamentally the same. So I think two others that I would comment on, which often I do have patients approach me, are individuals who are under the age of 25. So there is obviously some concern about in terms of individuals who are under that age group. They still, these young adolescents still have a developing brain. So the recommendation to avoid in those individuals is to avoid, the potential negative impacts that cannabis can have on those young adolescent individuals. And then the second, which often does come up as well, and I think we always take a very safe approach towards, is women of childbearing age who are either planning to become pregnant, are pregnant, or planning to breastfeed. Again, because of the potential consequence of cannabis use in these individuals on the fetus and or the transmission through breast milk. One other thing that I'd like to comment, just based on my own experiences, is as being a palliative care physician and having a large cancer population of patients, is that one of the, I would say probably the newest or relatively new in terms of data that's come out is, again, a drug-drug interaction between certain immunotherapy agents. So such as, monoclonal antibody medications such as nivolumab, which again is used relatively in specific types of cancers. So patients with advanced melanoma, renal cell carcinoma, or non-small cell lung cancer. That's a sort of a question and a discussion that I have with patients, and often at times with oncologists, about the potential drug-drug interaction with that type of immunotherapy agent. Not what we see with the other traditional platinum-based chemos. We don't see any drug-drug interaction with cannabis and those agents, but with immunotherapy agents, we can see, and we have seen from a couple of studies from 2019, although they are retrospective and a prospective observation study, they did find that in individuals who used cannabis and were on immunotherapy, there was a decrease in the response rate of that drug. So meaning that the efficacy of that drug did go down, although that did not change any outcome in terms of overall survival or progression-free survival. So again, the take-home point is that it's not an absolute contraindication, but I think we need to understand what is the goals of care, what is the intent of using cannabis for very specific patients. And in that patient population, if the intent is, if they really have a disease and the intent is to cure their cancer with this type of immunotherapy, then I will have a heart-to-heart conversation with them, including their oncologist, that there might be a decrease in the efficacy of that drug. Now, in patients, again, who have, let's say, metastatic or advanced stage 4 cancer, well, then we really need to establish what is the goals of care. If we understand that there might be a decrease in the efficacy of that drug, but again, the intent is that we're using cannabis to, reduce symptom burden or improve quality of life, then that's a discussion that needs to be had. So those are probably my, my take-home points about cannabis and specific medications.
Great, thank you for that. And Jehan, our I guess resident researcher. So what have you seen? Do you see any studies that show different methods of ingestion versus, inhalation via smoking, vaporization to a tincture to an edible, and also playing an effect in this?
Yeah, I think definitely the route of administration and the chemical variety or the chemical makeup of the product can come into play. So, if it seems like from what I'm hearing from everyone here saying, if the patient comes in and is checking a lot of boxes in terms of problematic substance use, unstable blood pressure, unstable cardiac issues, and they come in wanting to use a high THC or pure THC product, you might be like, maybe it's the safety of the product, not the product category itself. Oh, you also smoke tobacco and e-cigarettes. Well, I don't really want you to be using a product that you might smoke as well, because also just with smoking not being, recommended by doctors, I think in the US since the 50s, right? but we want to think about those issues. And I think that the administration form can play a role. Other considerations, I think, are where they're getting the product. And I think that could change the contraindication. So again, we have to always be careful. We're talking about a patient checking in about their cannabis use as an adult or their medical cannabis use. And I think there could be some different considerations there, like if they're immunocompromised and they're using cannabis, smoking it recreationally. I think that has always been an issue, because even if the product is tested and pass those microbial tests, you still don't want any microbes. So I think route of administration there could also play a role. And what I'm hearing from our lovely panelists today is that it sounds to me like if it's going to be adult use of cannabis and you're checking in with a patient, it's kind of like the rules for a roller coaster. Like if you have a heart issue, if you are prone to going unconscious or have these other, respiratory issues, then, consider alternatives. But with a medical cannabis patient, I really liked hearing all these considerations, like perhaps there are extreme conditions like end stage liver disease or chronic kidney disorders, where you might want to really consider the route of administration and as everyone talked about, drug interactions. Any population that's vulnerable, that's a polypharmacy population. This includes the elderly. And again, the cannabis use disorder scale exists. You can play it at home if you want. But it's always interesting to see where people fall. It's not a perfect scale because most patients who use cannabis every day will test mild to moderate on it. But, just to wrap it up, I think, it's just a great handy scale. It could be applied to anything. It could be applied to raspberries. If I was showing up to this call with eating 6 crates of raspberries, I had stains on my teeth and I was missing work to go buy more raspberries. And I was just had raspberry themed shirt and hat on, you'd be like, wow, I think you might have an issue with raspberries. So
Raspberry use disorder. I love
yeah,
it.
so I think it's just a good thing to check in on and have that discussion. So those are usually the things I talk about when I teach CME in terms of contraindications. Of course, the big one I should mention too is mental health issues are important to consider, as been mentioned. So I guess I should have just started with, I agree with everything everyone has
I
said
agree.
already.
I concur. I concur.
But
You,
let me
you know, I know
devil's
you spoke.
advocate for a second.
Yeah, of course.
So, a bunch of years ago, I had a 70-year-old woman come to see me, and she had terrible diffuse arthritis pain, and she had been on every substance known to man, and it wasn't working, and she was miserable, right? So in and of itself, the indication for cannabis use was pretty straightforward. On the other hand, this woman had a long history of mental health issues. She had had a florid psychotic episode in her 20s. She's now 70, right? But subsequently, she's been in and out of the hospital, and she had 2 psychiatrists and 2 psychologists who followed her. She saw the psychologist, one of them 5 days a week and the other one 7 days a week. I have no idea how she got herself that hooked up. But, the question was, okay, where in that continuum of relative contraindication does this woman fall? Because she's clearly got some pretty significant mental health issues, as well as some pretty significant pain and quality of life issues. And so it was pretty hard to figure out how to balance that. So what I did was what Dr. Tandon had suggested. I talked to her mental health providers, and we all came to the conclusion that she was probably pretty stable, and that she had lots of eyeballs on her all day, pretty much every day. And so we decided to proceed. And it turned out that she didn't do very well on cannabis for other reasons, having nothing to do with her illness. But the point was that was another complicated calculus, and it was very helpful to kind of get the team on the same page.
Yeah, well, to that, Jordan, what comes to mind is, if this patient was trying, and again, I'm not a clinician, I just get to talk to clinicians and do a little bit of clinical research. So definitely would want other people's opinions here. But, from what I'm hearing, if I was writing this up as a case report, one of the things I would talk about is, well, this patient took lots of medications. Did they experience a lot of adverse events with those medications? Because, there's some people who are like nervous Nellies, right? They'll take a drug and they'll have every adverse effect. And then some people are like, I didn't feel anything, or, yeah, I don't know what that commercial was about with all those side effects. I felt nothing, And so I think, to your point, that could be something that trumps it, is if this person can metabolize the drug and seems to tolerate the side effects of other medications, especially, in a treatment resistant condition. That's and again, I'm looking to all of you, that seems like might be something to balance with your consideration, even though, like you said, she checks these other boxes for contraindications.
Just to
I
add
think-
to it. Oh, sorry.
Yep, but no, I was
I
just
wanted
gonna say that it's
add to the excellent sort of conversation here is that I think we need to understand that with cannabis, as we're learning more about it, these contraindications, or the term contraindication, it's not really black and white. There's a lot of gray, and I think what we need to do, as Jordan mentioned, as Jehan mentioned, is to utilize all the allied healthcare providers who can put eyeballs on our patients to ensure that we're mitigating the risk and the side effects. And that way we could really lessen, the term contraindication, keep it maybe relative, but really we just need to practice medicine, right? So that's my point about it.
I was going to add to that as well, and you kind of touched up on that, Jehan, is that what do you do with your patients that have, I guess, side effects, negative side effects, and brings on the paranoia, the schizophrenia, and other mental issues come up. Do you, I don't want to say, do you have time to follow up with your patients? Do you normally do with patients? What can you recommend to a new doctor that's coming in, that's learning from you all, of what to look out for, what questions to ask, what ailments to really put on the top of their list?
Well, I would just say, if you have any unwanted side effect, whether it's you didn't get high, you got too high, whatever it is, most jurisdictions have a poison control center somewhere you can report the adverse event. And so just to jump in, I'd say from an epidemiology perspective, we need more and more information about this, especially with this explosion of product diversity. So I'd say be sure to document it. But I didn't mean to interrupt the
No,
good
you're never
doctors.
going. But one thing about documenting, I'm a fan of journaling as well, knowing exactly what time you took it. Did you have food in your system? Did you sleep the night before? What other medications? So journaling is huge. And then I know you're also, as we all are, big on safe tested medicine, making sure there's no pesticides, mold, fecal matter. People laugh at me, but I work with so many scientists. They said, you'd be surprised at what we find in people's medicine. There's a lab out here in the San Francisco Bay Area that I think they said 75% of the products that come in are contaminated, yet 100, before all these new rules with regulation came out, but yet 100% of the products still went to market. I mean, that's scary, especially when you have an immune compromised patient that that cannot. I mean, it's scary what's out there, and I hope this industry continues where we're going, and countries like Colombia and Panama, also lead the way to show what the importance of safety. And it's a plant, but it's also a medicine for a lot of people, and we look at it that way too. So I know we're coming to the end, closing out here. Do you guys have any final words?
Well, I would like to add something that is very important as we started this conversation, is cannabis, or medical cannabis, is not for everybody. Yep. So it's very important that the patient is aware of that. And the practice, in my clinical practice for doctors, the advice is you have to take the time. For me, I take almost 1 hour when my patient comes for the first time, and it's not just that. I have to do a follow-up like every 3 days, then at the 6, and even a titration could even take 3 weeks. So it is not we cannot rush this. Good. Because by rushing is that we start seeing the side effects and this. And as Jahan commented, is if you start a titration, and maybe will sound cliche again to say start slow, go slow, but it's, for me, the way that it makes me feel safe, that I'm not going to have like a bad reaction or something really catastrophic for the patient, because I will be monitoring every 3rd day the patients, and in our clinics We have a software that give us alerts and allows the patients to report something and send the doctor an alarm or something. And of course, the pharmacovigilance programs is super important because we will report the products that they are causing certain side effects. So I think we are just scratching the surface. We are all learning about this cannabinoid prescription, but I think we're making a lot of progress, and teaching is the base of all of this.
Well, it sounds like you're definitely leading the way and being a pioneer down there, because I think here in America that I think they're still trying to figure out what's going on. In 1996, California was legal at the medical level, and I remember I had a doctor from the Department of Health call me one time, and he said, I've been put on this saying, can you share some things that California did incorrectly, because I've been put on this. And a year later, he called me. He said, "Do you remember?" I said, "Of course I remember." He says, "I've been put back on this case. Can you share some things that Colorado is doing incorrectly that we can improve?" And I just think all putting our pluses and minuses and successes and failures together, and then again putting patients first too. So, Dr. Carrillo, thank you very much for joining us, and we look forward to having you on our next call. Dr. Raku, always great to see you. Dr. Tandon, the same. And Dr. Tischler with the Association of Cannabinoid Specialists. And if you'd like to share, Dr. Tischler, how others can join us.
Oh, yes. Thank you. Listen, if you're a physician or other clinician and you're thinking about this kind of medicine, do join the Association of Cannabinoid Specialists. Come visit us on the web at cannaspecialist.org. That's cannaspecialists.org. We have a whole bunch of free resources. If you join, there are a whole bunch of other educational resources. And then we have some very deep educational courses that you can take. You get a discount as a member on those sorts of things. And then my favorite, of course, is we do mentoring for people. It's sort of like how we used to do morning report. So we get together and talk about cases and put our heads together and essentially just trying to make sure that we're taking the best care of our patients. So please, again, cannaspecialist.org.
And just want to follow up on that. It's global is welcome. So it's not just here in America.
Absolutely.
And so everyone is welcome. And Dr. Carrillo, coming up, I know you mentioned, I don't know if there's a date yet, but there is going to be a conference that Dr. Carrillo is putting on down in Medellin, Colombia. And do we have a year or a date or a month yet, or not yet? To be continued.
Well, probably will be in October in Colombia, in Medellin, and another one I'm planning in Panama for August. Of course, with the pandemic, it's very hard to do this. And I just want to say that I am board member of ACS, and I find it extremely, extremely important for all the doctors and healthcare practitioners to be part of scientific associations, because it's the only way to find reliable information, because people is finding all types of information in internet that they are not realistic. And for a doctor, we need to be members of scientific associations. So I hope to see all of you at the conferences, because the education is the key to destigmatize the use of cannabis as medicine.
As medicine, great. Well, thank you all for everything, and thank you for our listeners. This is John Malanka signing off, Association of Cannabinoid Specialists. We will see you on our next segment. Everyone, a wonderful day, everyone. Bye-bye.